Alrighty, well, good afternoon, everyone, and welcome to this informational webinar on changes to Medicare in 2024, which is hosted by U.S. Senator Bob Casey's office and the Centers for Medicare and Medicaid Services. We're grateful for everyone taking the time to join this call today. I want to start by introducing myself and the other panelists on this call. My name is Andrea Guscott, and I'm one of Senator Bob Casey's constituent advocates. Also on this call from Senator Casey's office is constituent advocate Maria Hernandez. From the Centers for Medicare and Medicaid Services, we're excited to introduce Patrick Hamilton, as well as Monique Scott, and we're grateful for both of their willingness to join our office for today's webinar. Before we get started, I'll quickly note that if you have any questions, please hold them until the end of the presentation when we will have a Q&A session. We ask that you please keep these questions general and applicable to as many people as possible since this is a public call. And if you have questions regarding your own specific situation, contact information for Senator Casey's office will be provided during the presentation for you to reach out to directly. And at this time, I'm going to turn the call over to Patrick to delve more into the specifics.
There we go. Good afternoon, everybody. Can you hear me, Andrea?
Yep, we can hear you.
Great. Thank you. It's great to be here. Thank you for having me today. My name is Patrick Hamilton. I am with the Philadelphia Regional Office of the Centers for Medicare and Medicaid Services in the Office of Program Operations and Local Engagement, or OPAL. And basically, our mission is to conduct provider, consumer, and congressional outreach so that you are well apprised of the latest and greatest of what's going on in Medicare, Medicaid, and marketplace programs. I work alongside my colleague, Monique Scott, who is our congressional liaison. She's joining me on the call today. And I'm going to go over some of the updates and some of the new stuff that's going on in Medicare in 2024. By way of background, I've been with the agency since 1998. My original job was in the area of provider outreach. So I come with a big, long history of doing provider outreach. I'm talking about Medicare Part A and Part B. I was also rural health coordinator for a number of years, and I worked extensively in the quality payment program before I moved over to become special assistant to our regional administrator, Sharon Graham, here in the Philadelphia office. So we are going to get started, and let me just make sure that I can advance my slides. There we go. Okay, so disclaimer slide, we show this at the start of all of our presentations. This presentation was developed and approved by the Centers for Medicare and Medicaid Services, which is the federal agency that administers Medicare, Medicaid, and the Children's Health Insurance Program, as well as the Health Insurance Marketplace. Collectively, we sometimes call them as the 3 M's. The information that is being shared is current at the time of this presentation, but the policy is subject to change. This presentation is intended only to provide clarity to the public regarding existing requirements and rules. So now that we got that out of the way, so what I'm going to do is I'm going to give a little bit of a combination of some basics. So if there are folks who are on the call who are new to Medicare or have never really had the Medicare 101 training, I'm not going to spend my entire time doing that, but I want to make sure that everyone has at least a basic understanding of how Medicare works. And from what I'm told, this audience pretty much has a pretty good idea of Medicare, but I just want to cover all my bases. So some of this may be kind of 101 to you, but bear with me. So when someone starts in the Medicare program, or when they first enroll, they have two choices or two avenues by which they can receive their benefits. They can get what is called original Medicare, or sometimes we call it traditional Medicare, or Medicare Advantage, which is called Part C. Now, Part C, Medicare Advantage, was developed before Medicare Part D, which is the drug coverage, which I will talk about. So that's why we say A, B, and D are original Medicare, and then Part C, because Part C came first, and Part D just happens to also start with drugs, but Part D was actually just the next letter in the alphabet. So that's why it's ABD for Part C. So original Medicare covers Part A and Part B. We're going to go over briefly what is covered in both of those parts. And then if one wants drug coverage, then they join a separate drug plan, private drug plan, which is part of the Part D program. And the good thing about original Medicare is that you can see any doctor or any hospital in the United States that takes Medicare, that accepts assignment. And then to help pay for your out-of-pocket cost, if you're in original Medicare, you can get something called Medigap, which is supplemental coverage. It only works with original Medicare if you partake in Medicare Advantage plan that would not pertain to Medicare Advantage. The Medigap plans could offer additional benefits in addition to what is covered under traditional Part A or Part B, and you would pay an additional monthly charge for that. Medicare Advantage, as I mentioned, Part C, is a Medicare approved plan from a private company that offers an alternative to original Medicare for your health and usually drug coverage. So think of it as a bundled plan for Parts A, B, and usually Part D. Plans may have lower out-of-pocket costs, but most frequently you will pay an additional monthly premium on top of your Part B premium. And in most cases, you need to use the doctors that are in the networks for the plans for which you sign up. So that's something very much to keep in mind. We are in the midst of 2 enrollment periods right now. So we are right now in the general enrollment period. So if someone did not sign up for Part B or for Part A, if you have to buy it, and I'll explain why you would have to buy it in a few slides, during your initial enrollment period, and that's the enrollment period around the month that you turn 65. So think of it as the month that you turn 65, 3 months prior to that month, and 3 months after that month. So you have a 7-month initial enrollment period during which you should sign up for Medicare. But if you don't, then you have 3 months in the beginning of the year from January 1st through March 31st, and we call that the general enrollment period. Your coverage starts the first day of the month after you sign up. You may have to pay a higher Part A and or Part B premium for late enrollment. So for most people who don't sign up during their initial enrollment period, or if they don't qualify for what's known as a special enrollment period, which I will talk about also in a few slides, then this is their only chance to sign up. So it's very important to pay attention to the general enrollment period. But if you've delayed signing up for Part B or Part A, if you have to buy it, because you or your spouse were still working and you had group health plan coverage, then you will not have a late enrollment penalty, and you may be able to sign up during a special enrollment period. We are also in the midst of the Medicare, and one slide is not advancing. For some reason, it does not want to show the Medicare Advantage open enrollment period, but January 1st through March 31st is also the Medicare Advantage open enrollment period. So that enrollment period, also coverage begins the first day of the month after you join the plan. You must be enrolled in Medicare Advantage plan at any time during the first 3 months of the year to use this enrollment period. So this is very specific. It's for folks who are already in Medicare Advantage or Part C plan. And during this enrollment period, you can either, if you are in a Medicare Advantage plan, you can switch to another Medicare Advantage plan, and that's either if it has drug coverage or it does not. Or during this enrollment period, you can drop your Medicare Advantage plan and return to original Medicare. And then during that time, you will also be able to join a separate Part D plan because there is a special enrollment period tied to that. You cannot switch from original Medicare into a Medicare Advantage plan during this time period. That happened in the fall during the open enrollment period. And can also not join a drug plan if you're an original Medicare. You had to do that before December 7th. Now, Section 120 of the Consolidated Appropriations Act gave the Secretary of Health and Human Services the authority to establish special enrollment periods. These special enrollment periods give people who qualify a chance to enroll without having to wait for this general enrollment period that we're in right now, and usually without having to pay any late enrollment penalties. I'm going to go into detail as to what those penalties are in a moment. So specifically, the legislation that is referenced here created 5 new SEPs. So SEPs one is for people who are impacted by an emergency or a disaster. People get inaccurate or misleading information from their health plan or their employer. People who were formerly incarcerated and may have aged into Medicare. People who are losing Medicaid coverage rather. So many of you may be working with folks through the Medicare redetermination or unwinding process. There's a special enrollment period for Medicare for those folks who are going through the redetermination process and being determined no longer eligible for Medicaid, but they have since aged into Medicare, or they may qualify Medicare for one of the other couple of reasons. But most people that would qualify for this SEP aged into the program during the public health emergency, and then other exceptional conditions. So we have more information, fact sheets available for those special enrollment periods. So again, I'm going to very briefly go over what is covered for Part A. It's inpatient hospital care, which is a semi-private room, meals, general nursing, drugs, and other hospital services and supplies as part of your inpatient treatment. And that includes care that you get in acute care hospitals, critical access hospitals, inpatient rehabilitation facilities, long-term care hospitals, and psychiatric care in inpatient psychiatric facilities. All people with Part A are covered for inpatient hospital care when you are admitted to the hospital as an inpatient after an official doctor's order, which says you need inpatient hospital care to treat your illness or injury, and if the hospital accepts Medicare. In terms of skilled medical or skilled nursing facility care or SNF care, which is not custodial or long-term care, you have to meet certain criteria. SNF care includes safe and effective care given by skilled nursing or rehabilitative staff. Skilled nursing and therapy staff include registered nurses, licensed practical and vocational nurses, physical and occupational therapists, speech language pathologists, and audiologists. Part A also covers blood. So if you're an inpatient and you need blood, that is covered under your Part A benefit. Qualify for hospice care, a hospice doctor, and your doctor, if you have one, must certify that you're terminally ill, which means you have a life expectancy of 6 months or less. And when you agree to hospice care, you are agreeing to comfort or palliative care instead of care to cure your terminal illness. You also must sign a statement choosing hospice care instead of other Medicare covered treatments for your terminal illness and related conditions. Also, Part A covers home health care, and there is a segment of Part B that also covers home health. Medicare will cover home health services as long as you need part-time or intermittent skilled services, and as long as you are homebound, and there are specific criteria to determine whether or not a person meets that definition of homebound. So what do you pay for Part A in 2024? So about 99% of Medicare, people with Medicare do not pay a Part A premium, and that is because they paid at least 40 quarters of that pesky FICA tax that we all see on our paychecks. So if you work at least 40 quarters or 10 years of Medicare covered employment, then you will not pay the premium for Part A. However, there are instances, like I said, 99% of folks who qualify or enroll in Medicare do not pay for Part A. Sometimes we call that premium-free Part A. That is not free Part A because you paid into it. But for those who do have to pay, if you have less than 30 quarters of Medicare covered employment, it is $505 per month in 2024. And if you have between 30 and 39 quarters of coverage, then the reduced monthly premium is $278 per month. Now, if you are not eligible for premium-free Part A and you do not buy it when you're first eligible, your monthly premium may go up 10% for every 12 months you don't have the coverage. So you want to make sure that you enroll for that coverage as soon as you become eligible to avoid those premiums. So what you pay for in there we go. My keyboard is giving me some troubles today. So this is just an overview of the updated figures in 2024 of what you will pay. This is on the Part A side. So hospital inpatient stay, there is a $1,632 deductible for each benefit period. I'll explain what a benefit period is in a second for those of you who are not sure of the specific definitions. No co-insurance for each benefit period for the first 60 days, so day 1 through 60. Days 61 through 90, it's a $408 co-insurance per day. And then days 91 and beyond, $816 for each lifetime reserve day. And then if you require or need or request private duty nursing, television, phones in your room, things are not generally covered, then you will likely have an out-of-pocket cost for that as well. In terms of mental health inpatient days, you can see that the amounts are the same. However, there is no limit to the number of benefit periods you can have when you get mental health care in a general hospital. But this is important. If you're getting service as a psychiatric hospital, Part A only pays for up to 190 days of inpatient psychiatric care during your lifetime. And again, that is in a psychiatric hospital. In terms of skilled nursing facility stays in 2024, $0 for days 1 through 20, $204 per day for days 21 through 100. And then after 100 days, starting with day 101, all costs would be paid. Home health care, $0 for home health care services. For hospice services. Let me go back to home health care. $0 for covering home health care services, but 20% of the Medicare approved amount for DME, durable medical equipment for providers who accept assignment. For hospice, there's $0 for hospice care, but there could be a co-payment of up to $5 per prescription to manage pain and symptoms while at home, and 5% of the Medicare approved amount for inpatient respite care. I mentioned the benefit period. Benefit period refers to the way that original Medicare measures your use of hospital and SNF care. Benefit period begins the day you're admitted as an inpatient in a hospital or SNF. So the inpatient does not include observational care. So it's an actual admission, or when you go right into a SNF, if you go into the SNF before the hospital. The benefit period ends when you haven't gotten any inpatient care or SNF care for 60 days in a row. So if you go into the hospital or a SNF after one benefit period ends, then a new one begins. Moving over to Part B, so this is basically all of your outpatient services. So doctor services for any services that are medically necessary, outpatient medical and surgical services and supplies for approved procedures such as x-rays or stitches, clinical lab services like blood tests, urinalysis, and some screening tests, durable medical equipment, diabetic testing equipment, supplies, preventive services. We're going to talk about preventive services in the next slide, I believe. And then I mentioned there are some home health services that are also covered under Part B. The preventive services starting in 2011 with the Affordable Care Act CMS eliminated the deductible and co-insurance for most of the preventive services, and we have incrementally increased the preventive services that are covered under Medicare programs since the mid-2000s. And again, we ramped that up in 2011. And then we also, from time to time, continue to add preventive services, most of which I said, as I mentioned, are without deductible and co-insurance. There is a really great guide, a couple of great guides on the CMS website for preventive services. If you need more information, my contact information will be at the end. But there is a really, really great information that tells you about who's eligible, when people are eligible, coding, and everything like that. So definitely avail yourself of those resources if you need them. In terms of the premium for 2024, the standard premium is going to be $174.70. And for most people, the Part B premium is deducted from their Social Security benefit. But if the Social Security benefits aren't enough to cover the whole Part B premium, or if someone is no longer getting Social Security benefits, then a beneficiary is billed for Part B every 3 months. Now, remember that the premium might be higher if you didn't sign up for Part B when you first qualified for it. So there is a theme to this. Cost of Part B may go up 10% for each 12-month period that you could have had Part B, but it didn't sign up for it. That's something to keep in mind. We also have the income-related monthly adjusted amounts, or IRMA, and these are updated every year. So these are the amounts for 2024. And it's estimated that about 7% of people with Medicare actually pay this IRMA. So a big majority of people will pay just the $174.70 each month. But as you can see, I'm not going to go through all of the income ranges, but you can see where someone's income falls, whether or not they are filing their tax return jointly, or if they are married and filing separately, what their monthly Part B premium will be. The yearly deductible is $240. Of course, that's the amount of out-of-pocket costs before Medicare begins to pay. And then for most services, it's a 20% out or co-payment and that includes also for outpatient mental health services. We do have the Medicare savings programs, and we did a lot of outreach and education about this program over the last 2 years. We found out that many folks don't know about it. So we want to make sure that people can get help from the state paying Medicare costs if someone has limited income and resources. So these programs frequently have higher income and resource guidelines than full Medicaid and are helpful if you had premium tax credits or cost sharing reductions in the marketplace. So we're doing a lot of outreach also for people that are aging into Medicare directly from the health insurance marketplace. And there is a system of tax credits and cost sharing reductions that were available to folks. So we want to make sure that those people in particular who are coming into the Medicare program know about these programs. So collectively, we call these Medicare savings programs, and you can see that there are 4 here: the qualified Medicare beneficiary, or QINB, specified low-income Medicare beneficiary, or SLIMB, qualifying individual, QI, and qualified disabled working individuals. Those last 2 don't have a slick acronym that you can pronounce. So we say QINB, SLIMB, QI, and QW, or QDW. So eligibility for these programs is determined by income and resource levels, and we actually have those on this next slide. So as you can see, for the different programs, there are different income levels, income limits, both for individuals and for married people. Moving over to Part D, I want to spend a little bit of time on Part D because we're going to talk about the Inflation Reduction Act and some of the provisions in the IRA that are specific in 2024 as it relates to Part D. So as I mentioned, Medicare contracts with private insurance companies that offer drug plans to people with Medicare. Everyone with Medicare can get drug coverage by joining a drug plan, Part D. Again, this is for people that are in original or traditional Medicare. And again, if you don't get Part D when you're first eligible and you don't have other creditable coverage, then you may have to pay a penalty for as long as you have a drug plan. And also get a drug plan through Medicare Advantage. As I mentioned, most Medicare Advantage plans have drug plans, but they all don't. But that's one of the things you want to take into consideration when you are shopping for Medicare Advantage. Each plan has a formulary or a list of covered drugs. And those formularies can change every year, and a notice has to go out so that people who are part of that drug plan know of changes that may affect them in advance of the open enrollment period, so that if folks have to make changes based on changed formularies, and they have that information. All plans must cover a wide range of drugs that people with Medicare take, including most drugs in certain protected classes, which include cancer drugs, HIV/AIDS drugs, antidepressants, antipsychotics, anticonvulsants, and immunosuppressants for organ transplants. So there is a monthly premium that most plans will have, as well as a yearly deductible. There's co-payments or co-insurance. And again, this is all going to vary by plan. It's also going to vary by income level and whether or not you automatically qualify for extra help or you proactively apply for extra help and you are approved for it. The percentage of the costs, while in the coverage gap begins for out-of-pocket spending, which is $5,030 in 2024. That's the coverage gap. And then very little spending once you get into the catastrophic phase or catastrophic coverage, which in 2024 is when you hit $8,000 in out-of-pocket costs. We're going to review the changes to extra help via the IRA in a few slides. Again, there is an IRMA for Part D, and as you can see, the dollar amounts are the same as the Part B IRMA. So basically, it is a set amount plus the plan amount. So that's why we say it's going to be $12.90 plus whatever the plan amount was for the yearly or the plan premium, and that would be for the month. As you probably guess, there is a late enrollment penalty for Part D. if you don't join the drug plan during your initial enrollment period and you go for at least 63 days in a row without Part D or other creditable coverage. So what is credible coverage? So think of things such as coverage from a current or former employee or union, coverage from TRICARE, from Indian Health Services, the Department of Veterans Affairs, or individual health insurance coverage. So Medicare calculates the late enrollment period by multiplying 1% times the number of full uncovered months that you didn't have drug coverage once that you qualified for that coverage, or other credible coverage as much as Medicare's standard drug coverage. And that's multiplied by the current national base beneficiary premium, which in 2024 is $34.70. The final amount is rounded up to the nearest dime, so the nearest 10 cents, and added to your plan's monthly premium. So again, the message here is once one is qualified or is able to enroll into Medicare, they should do so at that time. So we're going to talk about the Inflation Reduction Act and the provisions. First of all, the Inflation Reduction Act, everyone knows, a huge monumental piece of legislation. A lot of things in there for people with Medicare and also people in the health insurance marketplace. We're going to focus on the provisions that pertain to people with Medicare. So these are the provisions that started last year in 2023. And the headlines for people with Medicare, of course, was insulin cost sharing. So starting in January 1st of last year, people who were enrolled in Medicare were not paying for more than $35 for a month's supply of each insulin under Part D. And then that $35 cap for each insulin product went into effect for Part B. So if you were getting your insulin through a pump in an office setting. Vaccine cost sharing also went into effect starting January 1st. So all vaccines are recommended by ACIP, including shingles, were available under Part D at no cost to them. And then also adults with coverage from Medicaid and CHIP were guaranteed coverage of vaccines, also recommended by ACIP, starting on October 1st at no cost to them. And then, of course, we started the Medicare the drug price negotiation program for Medicare Part D. We announced the first 10 drugs that were going to be subject to price negotiation. We are happy to say that before the end of 2023, all 10 drug manufacturers agreed to or entered into agreements to start that process. So there's going to be a lot of work that will be done in 2024 to start the first 10 drugs that we announced last year for 2026. In 2024, we are very excited to be expanding the low-income subsidy program or the extra help program, and we'll go into details as to what that is starting this year. I also want to make sure that people know that the catastrophic phase, first bullet point of the Medicare prescription drug benefit, starting this month, January 1st, that people who fall into that catastrophic phase of the prescription drug benefit will no longer have to pay any co-insurance or co-payments when they're in the catastrophic phase. So what is the Extra Help program? So Extra Help is a Medicare program to help people with limited income and resources pay Medicare drug program costs, such as premiums, deductibles, and co-insurance. If you have the lowest income and resources, you'll pay no premiums or deductibles and have small or no co-payments. And before, if you have slightly higher income resources, you'll have reduced deductible and pay a little more out of pocket. So we had something that was called partial extra help. What the IRA is doing this year is eliminating that partial extra help. And for those folks that were part of that partial extra help will now become eligible for full extra help. So that's what we mean by expansion of the extra help program. The beginning in January, nearly 300,000 low-income people with Medicare who are currently enrolled in the Extra Help program will be newly eligible for the expanded benefits. So those are the folks that were getting partial extra help. We also estimate that there are maybe 3 million people who could benefit from the Extra Help program right now who are not currently enrolled. So we are working to make sure that people are getting the word that this extra help for their Part D prescription drug coverage is available and they should definitely enroll, apply for it if they do not automatically qualify for it. We'll talk about automatic qualification in a second. People with extra help. Right. So the people that are moving from the partial benefits into the full benefits will also pay no deductible, no premium, fixed lower co-payments for certain medications, and could save almost $300 per year on average, according to estimates. Now, as I mentioned, there are some people that will automatically qualify for this extra help, and those are people who are on Medicare and also get full Medicaid coverage, as we sometimes refer to them as fully dually eligible or dual full duals. Or if you're getting supplemental security income, SSI benefits, or help from Medicaid paying for your Medicare Part B through the Medicare savings programs. However, if you don't fall into one of those categories, you can still qualify or you can still apply. You just have to go through the application process, and you do that through the Social Security Administration. You can either do that online at the link there. You can also complete a paper application, or you can call Social Security at their 800 number. All right, so I want to wrap up and go through a couple of items that pertain to people with Medicare, but were provisions of the Medicare physician fee schedule. And Medicare physician fee schedule, for those of you who are not aware, that that's really the provider part of it. So that is when we make revisions to coverage policy, payment policy, implement new things that really affect the physicians and the practitioners and clinicians. But there are certain things that have a direct impact on people with Medicare, their patients. So I'm going to go through them quickly as I see that my time is running out. I want to talk about telehealth. So we have talked to a myriad of partners during the pandemic, and by far the expansion of Medicare telehealth has been one of the godsends during the pandemic. Before the pandemic, the Medicare telehealth benefit was quite limited in that it could only take place in a rural area and in specific ways that we define what a rural area is. The originating sites were limited, meaning where the practitioner could be located. The provider types who could perform or give services via telehealth were also limited. The services were limited. There was a very finite, clearly defined, narrowly defined list of services. Again, this is pre-pandemic, that practitioners could bill if they provided over telehealth. FQHCs, federally qualified health centers and rural health clinics, could not participate in telehealth. And there had to be a two-way audio video communication portal, meaning basically a camera and video and audio. So think, camera before Skype, before Zoom, which was not as rare, or was not as common as it was today. And that also, a lot of people with Medicare were very uncomfortable with telehealth and did not want to do audio video. So through the pandemic and through a number of steps that we were able, the permissions that we were given, authorities we were given from the secretary, we were able to suspend most, if not all, of those provisions. So we are now continuing to cover telehealth across the country, not just in rural areas. Originating sites are basically anywhere, including still at the home. We've greatly expanded the providers, the provider types who can give telehealth services. The list of telehealth services has greatly expanded. And a lot of the services that were expanded over or during the pandemic will continue to be on that Medicare telehealth list after the pandemic or after the end of 2024. One of the pieces of legislation, and there's so many at this point, we continued the flexibilities for telehealth until the end of this calendar year. So even though the public health emergency ended last May, the telehealth provisions continue until the end of 2024. Now, I will tell you that in order to continue those, congressional or legislative action will have to take place. So what that means is that after December 31st, 2024, You must be in an office or medical facility located in a rural area for most telehealth services, and not all of the services that you currently can get through telehealth now today will necessarily be on the list after December 31st, 2024. I can tell you just in reading that there is some activity and there is a lot of interest for Congress to be looking at this bipartisanly. That's a word. I have no additional information. I'm not a prognosticator. I'm just telling you what I'm reading. But I know that there is interest in really looking at this. We've heard so many times you can't put toothpaste back in the tube, you can't put the genie back in the bottle. So people, people on Capitol Hill are really looking at this. So more to come. Hopefully, we will have more good news to share later in the year. We're also starting to pay this year chronic pain management and treatment services. So that would be for services for people living with chronic pain, and we define that as persistent or recurring pain for at least 3 months or longer. And they include pain assessment, medication management, and care coordination and planning. And the Part B deductible would apply, and the co-insurance would apply for those services. We're also taking a very expansive look at mental health, especially specifically mental health care. We have a behavioral health strategy that is all encompassing. We'll talk about mental health, pain management, and opioid use disorder. So we are continuing to expand the mental health services that are offered to Medicare. And we are also, for the first time, starting in January of this year, paying for the services of marriage and family health services and mental health counselors. So this is big. So this is a whole new provider type or provider types who are providing critical services who are now going to be able to be reimbursed. Previously, the only way that they possibly could have been reimbursed if they were providing services that were incident to a physician office visit. So this greatly enhances and expands mental health services that are available to people with Medicare. We also in CMS are in the midst of a caregiver campaign as well. And we are beginning to pay for training services for those who are caring for people with Medicare. So that is something that's also starting. We're also starting to expand very incrementally, very smallly, I understand, dental and oral health services. We have at CMS 13 cross-cutting initiatives, and dental and oral health is one of them. Historically, very, very, very limited dental services as related to cancer. The new services that are being implemented in 2024 as it relates still are specific to head and neck cancer. But as you can see, we are starting to open that up. I will tell you too that we, over I think it was the last 2 years, hired for the first time a chief dental officer, Natalia Chalmers. So that is indicative of this administration's level of import in increasing dental services. So hopefully more on that front is coming as well. I also want to make mention of a new place of service code that went into effect this year, and that is to treat folks who are experiencing homelessness. So this is a new place of service code, outreach site / street, and it's defined, as you can see here, as a non-permanent location on the street or found environment described by any other place of service code where health professionals provide preventive screening, diagnostic, and or treatment services to unsheltered homeless individuals. The providers are now able to differentiate between mobile care and street care, and that really allows for improved data of healthcare needs for individuals who are experiencing homelessness. So I think that is a very important expansion as well. I want to remind everybody about coverage. Sorry about that. Keyboard issues again. COVID-19 coverage. People with Medicare still pay nothing for the COVID-19 vaccines. Diagnostic laboratory tests are still, you will pay nothing for diagnostic laboratory tests if they are ordered by a doctor. We've been getting questions with the uptick of the new variant as to whether or not Medicare is in discussions to offer, to pay for over-the-counter tests. And as of right now, we don't have any information that that is happening. So if you can avail yourself of any of the programs to send away for 4 or 8 or however many home testing kits. Definitely tell your clients and tell all of your patients to make sure you do that because we are getting a pretty big uptick. I think saw something. This is the biggest uptick since Omicron in 2021, I think. So testing is of the utmost importance, but statutorily, Medicare cannot pay for over-the-counter items. So that's the answer to that question. We are continuing to pay for the monoclonal antibody treatments and products. People with Medicare pay nothing for this treatment. If you get it from a Medicare provider or supplier, Medicare will cover antibody treatments if you have COVID-19 symptoms. So that is COVID-19 in a nutshell. I want to leave you with some Medicare resources. And Andrea, I will make available a copy of this PowerPoint presentation. I'll send it to you after the call, and you'll be able to share the links. It should work. So anything that we link to in the presentation, you should be able to avail yourself of those links. And all these products are available online and also for order. Before I go, I ask that this is the important slide. So we're always collecting feedback on our presentations. So we want to make sure that the information that we presented to you was relevant and something that was useful for you, that hopefully you learned some things that you didn't know before. So if you could either use this QR code or if you can go to the address, which I don't see the address. Anyway, so if you just put up your phone with the QR code, or Andrea, I can also send the link to the QR code. I don't know why it's not on the slide, but if you just snap your phone, that'll take you directly to the form that we use. I think it's 7 questions. It's basically to give us an idea whether or not we are meeting your needs. I only ask that when they ask you what the name of the presentation is, if you can put the number 3 in front of Medicare 2024 presentation or whatever you call it, as long as it has the number 3 and I know the date, we'll know that the feedback pertains to this presentation, because all the feedback that we get for all of our presentations basically go into one location, and then we go through and we sort out the ones for the individual events that we do. So if you just make sure you put a 3 on that one, that would be very helpful. I'll leave this up for just another couple seconds for those of you who were not able to scan it and be able to do so. And then, as I always say, the most important slide in my slide deck is how you get in touch with me after the presentation. So I will stay on to help answer questions to the extent that I can. My colleague Monique Scott is with me as well. But if there's anything that comes up, or if there's any need to contact you with any additional follow-up information that I can't provide during the Q&A, you have a way of making sure to get back in touch with me. So with that, I will turn it over to Andrea, and I will stay on the line.
Alrighty, well, thank you so much, Patrick, for sharing all that very important information. So now I'm going to quickly provide an overview on how Senator Casey's office may be of assistance to constituents regarding Medicare issues and navigating federal agencies. Go ahead to the next one. Thank you. So Senator Casey's Office of Constituent Services consists of a team of constituent advocates who assist constituents who are experiencing issues with a federal agency. This includes, but is not limited to, Social Security benefits, missing passports, IRS problems, VA benefits, immigration snags, SBA concerns, and so much more. It's important to note that if we cannot provide assistance, such as with a state or private entities, we can refer constituents to someone who can be best to help them. With regards to Medicare, we can assist constituents by reaching out to the Centers for Medicare and Medicaid Services, also called CMS, when it comes to Medicare coverage issues, and Medicare Advantage, also known as Part C, and Medicare Part D prescription drug plan issues. Common casework with CMS includes issues with claims payments, coordination of benefits, Medicare as a secondary payer, issues with Medicare enrollment, and coverage of medical equipment, home health, hospital, and hospice care. We can also assist constituents with navigating enrolling in Medicare Part A and B, which is handled by the Social Security Administration. If you would like to request assistance from Senator Casey's Office of Constituent Services, either with a Medicare question or for an issue with another federal agency, please do not hesitate to contact our office at the number 717-231-7540, and then you'll select option 2, or our toll-free number, which is 866-461-9159. And you can also reach out via Senator Casey's website. There is a link there, but the full link would be www.casey.senate.gov. So now we will open this portion of the presentation for questions for CMS or Senator Casey's office. If you have a question, you can click the raise hand button, which is at the bottom of the participants list to indicate that you have a question. I'll call on participants that have questions one by one and unmute you. And again, please remember that this is a public call, so we ask that you please keep your questions general. If you have a specific issue, please feel free to contact us via the information currently on the screen. And again, Patrick said he'll be sharing the slides, so I'll share that with everyone. But also this webinar is being recorded, and I will share that recording with everyone who has registered. All right, so first question I have is from Beth. Beth, you should be able to unmute yourself.
Question for Patrick. I just wanted to know a little bit more about the telehealth. I just want to make sure I'm clear. You were saying that at the end of 2024, unless Congress acts, those benefits will stop unless you're a rural constituent?
Right. So before the pandemic, there was, as I mentioned, the telehealth benefit was pretty narrowly defined, and it was originally developed to address the needs of rural patients. We were given the opportunity to expand that starting in March of 2020, so that basically everybody in any part of the United States was able to avail themselves of Medicare services through telehealth. Now, there is a defined list of those telehealth services, and we expanded that list as well. But that is correct. The idea was that when the public health emergency ended, those allowances or those exceptions were going to end. But because so many people have come to rely on telehealth, they extended it through a piece of legislation. I think it was the 2022 Consolidated Appropriations Act, I think, for all of those expansions to last through the end of this calendar year. But yes, if there is no additional legislative action, then it will revert back to pre-pandemic requirements.
Okay, thank you.
All right, thank you, Beth. All right, next question is from Lynn Cooper. Lynn, you should be able to unmute yourself. Okay, Lynn disconnected. But if anyone else has any questions, oh, Lynn's back. Lynn, you should be able to unmute yourself. Okay, it seems like Lynn's having some issues, but I have another question here from Pam. Pam, you should be able to unmute yourself.
Andrea, if people are unable to unmute themselves and ask their questions, you can ask them to send them either directly to myself, or if you want to receive them and then send them forward, and I can see if I can respond in email.
Yeah, absolutely. We'll do that then. when I send out or Lynn, it looks like you did unmute yourself.
I did. I'm so sorry.
That's
Technical
okay.
problems on my end. I tried 100 different things in that couple of minutes, and I apologize.
No
My
worries.
name is Lynn Cooper, and I work for the Pennsylvania Association of Area Agencies on Aging. And I was hired by the state association about 2.5 years ago to help our area agencies on aging access mental health and substance use disorder services in our communities, which access has typically been a pretty significant challenge for the folks served in the AAA centers. And this is absolutely great news about marriage and family therapists and mental health counselors. In fact, I lost my own therapist when I turned 65 because she was a licensed marriage and family therapist. So it's great news that that's happening. But the problem, I'm working with the state association that represents community mental health centers and drug and alcohol treatment providers. And what I've heard from them is that even though we have these two new practitioners able to provide care, that they're not moving forward to enroll in Medicare because of how difficult they believe the whole process of enrolling in Medicare and billing Medicare is way too complicated, and they don't have the staff to do it. And then their second big complaint is that the rates are still too low. And I think part of that is because we have Medicaid managed care in Pennsylvania, and the managed care companies have increased outpatient rates and other rates. My question is, what can CMS do to help us so that we can encourage more Medicare providers? I was just on a call this morning in a rural community like Bedford County. The federally qualified health center there is one of the very few that accept Medicare. Any thoughts?
Well, I mean, we always, we work with providers and potential providers into the program. The enrollment process, I'm not gonna lie, is arduous and can be daunting. There are resources that are available through both CMS and through the Medicare administrative contractors who are charged with the provider enrollment process in order to do so. In terms of the rates are generally set by legislation every year, so we can't really do too much about the rates. But to the extent that they are saying that the enrollment process is difficult, there are resources that are there that can help them through that process.
Great. Thank you, Patrick, for answering that question. If anyone else has any questions, feel free to raise your hand. I'll give it just a moment. All right, well, not seeing any other questions. If you do think of a question after the webinar, Patrick's information was shared, and I'll be sending out the recording as well as the PowerPoint slides in a few days. So you can reach out to me as well. Thank you for everyone for taking the time to join us today, and I hope you all have a wonderful rest of your day.